And if we take a look, what's very interesting again is here's the bone graft that's placed. One of the reasons that I like, if I'm going to come back and place an implant, why I prefer allograft bone, because it's a high turnover product, over bone that is xenograft in the socket, because it turns over more slowly. This has now been about 8 or 10 months, and that bone is clearly detectable in a radiograph. If we take a look, he has a high smile line, and I'm going to analyze this defect, my brother and I, and you take a look, here's the gingival margin discrepancy on the facial of the lateral. We also have an interproximal deficiency on this tooth and a slight one on the central incisor. And we're missing a large volume of the facial tissue as well. If you take the left central incisor and flip it over and make an identical copy of such, you now know the amount of deficiency you're actually dealing with. It's more substantial than you think. And this is easy to do in a wax-up if you don't want to do it digitally and show a patient. This is something that you can do just waxing it up. So we start to look at this case, and the first thing that I like to do is I want to go into this area and I want to graft it. But when I graft it with tissue, for those surgeons out there, I don't graft this area with tissue from the palate. And I don't graft this area with tissue that is allograft or xenograft in nature. Today I know a lot of people talking about that. This is tissue from the tuberosity. I like dense fibrous tissue because it doesn't shrink, and it may in fact help us with the vertical component of the ridge defect. So for vertical ridge defects, go to the tuberosity. We're now going to go ahead and we're going to bone sound. This is about 3 months after the tissue graft. We come back, we place our implant, and approximately 3 months later, I have the patient come back in, and my brother is going to temporize the implant. Henry temporizes this implant, but we still have a deficiency on the facial aspect and interdental aspect of the lateral incisor. And we're going to do something you guys have always seen, a little clinical pearl that's been around forever. Back in 1993, my brother and I published on utilizing this technique for implant dentistry. But we're just going to use orthodontics, a very, very light nickel titanium wire, to erupt the lateral incisor to bring down the bone on the facial and interproximally. And we do this with very light forces. And over a period of 3 months, we bring down the bone, and the bone brings down the soft tissue on the facial and interdentally next to the implant. And if you take a look at the x-ray before, you'll see where that bone was, and you'll see what we basically did is by erupting it approximately 2 to 3 millimeters, we were able to bring the bone down as you see here. And the concept, as I said, we published on back in 1993 and 1996, but a concept that was around since Jeff Ingber's work, one of my teachers. That's how we actually even thought of this back in 1976, where he leveled off osseous defects and gingival margins using orthodontics with retained teeth. So orthodontic extrusion allows for implant site development through the enhancement of hard and soft tissues. And it goes back quite a ways. So this is where we started. A defect caused by failed implant, substantial interproximal defect. This is what we were managing. And through the process of treatment, we were able to actually go ahead, place an implant, erupt the lateral incisor, and reconstruct this defect from a type 3 defect to a type 1 environment. So we utilized a couple of different tools, little tricks of the trade. But now we're left with another decision, one that's very, very significant. We transferred this restoration into a type 1 restored environment. Henry's very pleased. I'm very pleased with the result. The patient's very pleased. But now we have a question. What do you do with the lateral incisor? The lateral incisor is somewhat mobile. It's a short root. We've erupted it. It's about 1+ mobility. We don't really know what to do with this root, and we have a lot of different options. We can extract it and do a socket preservation technique. As you saw earlier, with thin bone, you may in fact lose some of the vertical and horizontal bone in the ridge. You can place another implant. You may in fact connect the tooth to the implant and splint it. But we all know that each one of those options has potential downside risk. So we placed an implant here. What are we going to do with the lateral incisor? And what are we going to do here which doesn't end up making an issue for us with all the tissue we grew on the facial and interproximal of that tooth? We don't want to lose what we created. And if you take out the tooth, because that bone has just recently been extruded by the tooth and it's thin, taking out a tooth, you may almost definitely lose some of the bone that you brought down with it. So it is an issue. How about placing a smaller diameter implant in the lateral position? 2 implants. Or keep the tooth. Or create a Pontic and do a cantilever Pontic off the single implant. These are all options to us. What we do know is that if we end up placing 2 implants, there are very strict ideas that we have to understand. We can only expect at the most 3.4 to 3.5 millimeters above the bone between 2 implants, even if that bone is retained. And an implant next to a tooth, 4.5 millimeters. We discussed that earlier. So what am I going to do here that's going to optimize the potential result? We talked about this earlier. If I can take an implant and put it next to a Pontic, these measurements are no longer the ones I'm working with. I'm now working around a measurement that's 5.5 millimeters. That's an extra 2 millimeters than I would have had around 2 adjacent implants, minimum. So what we did in this case, actually, and this is what you're seeing in the final case, is an implant and a Pontic, cantilever Pontic. But what did I do with the root? Well, what I did with the root is I left it in. I left it underneath the tissue. I cut the root down to the bone, but I didn't take it beyond the bone. I removed all the rough edges of the tooth, and I submerged it. And what I have now is an ideal environment for a Pontic where I can get 5.5 millimeters or more of tissue above the root. Now you take a look at how this ends up and the predictability long term. I don't lose any of the buccolingual contour. I don't lose the height of the interdental tissue. So we published this article in 2007, myself and my group in Atlanta. Submerged roots, what we said, allows for the maintenance of bone and supracrestal fibers above the head of the implant. Remember, it's the supracrestal fibers that make single implants so predictable. It is these fibers that we learned in dental school. Retained attachment and radicular fiber insertion. These fibers above the bone that actually oblique fibers that insert into the tooth are retained. And if you retain these fibers, you retain the tissue thickness and height. Around implants, these fibers run parallel, not horizontally. And they don't run transeptally. And what you're seeing here is exactly how you would section a root. You would section the root right down to the top of the alveolar bone. And because you retain these fibers, because you retain the periodontal ligament, you retain the potential of maintaining all three-dimensionally of the socket environment, unlike extractions where you could lose, even when you graft, up to 20%. So where do we learn this? What a trick, Dr. Salama. You must be a genius. Journal of Prosthetic Dentistry, 1980. If we go back to literature, you'll find we're not as smart as we think we are. Casey and Locello. The purpose of this article is to review and summarize in the literature. This is a summary article. They went back in the literature on the retention of submerged roots. And he said, it appears that submerged root procedures may have an accepted place alongside conventional overdenture techniques to retain bone. These were in cases where they kept the roots underneath the ridge to retain the bone under dentures. And if we know what we know is that if you end up taking out the tooth, not only are you going to lose some of the facial aspects because of this, but you're also going to lose the very important tissue interdentally. You'll lose the alveolus not only on the facial, but interproximally. So if we go back to this case that I showed you earlier, failure, this is what we ended up looking at. You have a patient who came in like this, and fortunately or unfortunately for this individual, the central incisor implant ended up failing. And we had to take that implant out. I had to open up this flap to take a look. This implant failed, took it out. Look at the defect that we're left with. Was this diagnosis? Was this something that was there previously? When we look at the pre-op CTs of this case, actually what ended up happening is once the patient was grafted, it was never diagnosed again. You have to reevaluate your bone grafts to see how much bone you actually got. And then you have to decide, should I place 2 implants? I mean, I think that this was the most difficult of environments because you didn't have enough bone to begin with, and then you place 2 implants next to one another. And you end up temporarily with a gentleman who has to get married with a transitional prosthesis like you see on the right screen. Now, I tried to talk him out of getting married. No, just because of the teeth. Just because of the teeth. He wouldn't listen to me. So when he was all done, his wife said, "I think you look fine. There's no reason to pay for further dental work." She came in for her own dental work. So we're now dealing with different kinds of environments. We sometimes lose teeth due to endodontic failure. Sometimes we lose them to some very, very, idiopathic reasons where we still don't know enough about it in the literature. Severe idiopathic root resorption. This patient, unfortunately, in her mid-30s, lost all her teeth. And what's very difficult about these cases is when you go in to extract the teeth, what you're looking up here is this amorphous material that's filled with giant cells and inflammatory cells, and you really can't tell what's bone, what's granulation tissue, and where the teeth are. So when I take out these teeth, I really like to go in there and use a piezoelectric device so I can kind of find my way down whatever remnant of periodontal ligament space I can get. And here all the teeth, they all break off at the necks because of the severe resorption. We end up with multiple extraction sites. And today, I place my implants because I want to retain her in a fixed, immediately loaded prosthesis. I pick my best implants that were secured beyond 40 Newton centimeters. I graft with a mixture of 50/50 xenograft product and mineralized irradiated bone. I place fibrin and pericardium in this area to cover over the top of the bone to make sure I consolidate it. And then several months later, once the back implants heal, I now have to come up to the front. These teeth are also resorbing. She's in pain, so we had to speed up treatment a little bit. These implants are in the back. Patient comes back in. I have to remove the anterior teeth. The anterior teeth are extracted, and what I did is exactly what I've just suggested to you. Rather than extract all the teeth and place in implants, I staggered my implant placement. I placed the implant in the central and the canine. I submerged the roots, and these were vital roots. These were not endodontically treated. You can see the redness in the pulp. These were teeth that were resorbing. I went beyond the resorption and went down to the bone on this area, making sure that you round off the corners. There's no sharp edges. And we place our implants. And you can see one of the things I also want to make sure everybody knows, always stay away from the labial. Never engage it, but never leave more than 2 millimeters of space here. This area will fill with bone. Now, some people suggest, Dr. Tarnow has been talking about, you don't need bone here, and you can just let blood clot fill. I believe that you do need bone here. If it's not osseointegration that you're looking for, it's trying to maintain the thickness of the ridge. So not only do I want to put bone in here, I may actually put something out here to compensate for any reduction in ridge thickness. On top of the roots, vital roots, I just placed PRGF, autologous PRGF. This is plasma-rich and growth factor and fibrin. I just cover over it, and I hike the tissue up. You don't have to achieve complete closure. What we know from the literature is that this can work. And the reason it works is because of some of the literature I'm about to show you. So here are the vital roots submerged the day of surgery. And we go ahead and do our grafts in this area. About 4 months later, we're going to expose one of the implants we placed. We now have staggered our anterior implants. And when David comes back to expose this one implant at the central incisor, you now have 3 retained vital roots under the tissue that are supporting optimized ovate Pontic form. So this is what the ridge looks like. Look at the buccal lingual. We didn't lose much because you didn't extract the tooth. Look at the height of the papilla. You didn't lose it because you didn't extract the tooth. He can then go ahead and pick up his impression. It's a full arch implant-supported restoration, and you can see with Duralay being painted into the ovate Pontics, he can transfer this information to the lab. And here's what it looks like. Sometime later on, this poor young lady ended up losing all of her teeth due to this idiopathic resorption. And this is what it looks like when we were done with the final ceramic restoration. I know you may think that that case never shows up again, right? Maybe once in a blue moon. This is the following year. Another patient that comes in. They're in different parts of the United States. I don't know if it's cell phones. I don't know if it's satellite dish. But something's going on because I'm seeing more of these cases than I've ever seen before. Look at the amount of resorption. This is tremendous. As a matter of fact, this patient came in because one of the teeth just broke off when she was eating bread. We go ahead and have to plan the same thing out. Multiple type 1 sites. The biggest thing is extraction, is not destroying the bone. Taking teeth out isn't difficult. It's how much bone you leave behind in the process. I use the piezoelectric device, as I talked about before. Piezo with a periotome tip allows me to engage that periodontal ligament space in that amorphous material. It's very difficult to locate what exactly is tooth structure and what's the granulation. At the same time, we placed a number of implants. We did a couple of bilateral sinuses for future implant placement. I didn't want to load these implants immediately, so I kept 5 teeth that were hopeless just in the first 2 to 3 months to retain the temporary while I waited for the first sets of implants to heal. And obviously, what ends up happening when you do that is immediately within the first week or 2, the patient ends up having endodontic pain because the resorption went into the roots. Brought the patient back 2 months later. Now, David goes ahead. We expose the implants that we placed first, and now I have this decision to make with you. I got 3 teeth here that are retained, but they're all cervical resorption that is happening, idiopathic resorption that's happened around her entire dentition. She's in pain. What am I going to do with these 3 teeth? Now, normally, if they were good teeth, healthy teeth without resorption, you just keep them. Segment your bridge. But this patient has a history of severe resorption. Much of what you saw happened over the last year. So what we've decided to do is, rather than extract an implant placement or socket graft, which is our other 2 options, we've decided just simply to submerge the roots. Vital teeth. We submerge them and we go over the top of those teeth with PRGF, or if you need soft tissue, you just drape over connective tissue. And now you can take a look at where we were here, and this is exactly 3 months later after those sockets have healed, and now Dr. Garber takes his final soft tissue impression. Is this new? Is it in the literature? It is. If you look at articles from the 1980s, from 1980 to 1983, 4 different articles on root banking to preserve alveolar bone. Clinical considerations for root submergence procedures. The effect of submerging roots with periodontal defects. Evian Rosenberg. These are my teachers at University of Pennsylvania, so I don't only steal from the literature, I steal from my instructors. And I let them know that I really appreciated it. General Dental Journal, 1983, ridge preservation through root submergence. This has been utilized predominantly for overdentures and predominantly for periodontal regeneration in the 60s, 70s, and 80s. What I'm simply doing is now utilizing it for soft tissue enhancement in multiple tooth replacement. The journal Perio, this is a big article that was published by Bowers and his group at Maryland. He said the greater percentage of positive regeneration of the attachment apparatus occurred around prepared root surfaces, around vital roots, retained their vitality, and cementum grew above the top of the prepared root surface. Cementum actually grew over the top of the teeth that were cut down, and they maintained their vascularity through anastomoses with the outer flap. So we take a look at this case. David now can take his rigid impression, making sure that there's no distortion. He then takes his vertical dimension registration. And if you take a look at the width of the ridge, no soft tissue grafts were done here. No socket seal, no xenograft. But look at the contour of this ridge for this patient. We've maintained it. We've maintained it by submerging 3 teeth. So this is what we look like towards the end as he's finalizing his work. Submerge root, submerge root, submerge root, and we actually have maintained a very nice scalloped restoration. So does root submergence work? I'm not telling you to go out there and cut every root down, but in certain specific situations with multiple tooth replacement, if you have a root, it can be utilized. Here's what the patient looked like when we started. This is now at the time of cementation of the bridge. If we take a look at more of the literature, there is some literature that doubts what we're talking about. Reevaluation of submerged roots in 1983, where they talked about, therefore, there is some doubt that remains as to the long-term success of this technique. What they did is they looked at cases 2 to 3 years out, and some patients experienced problems. I do want to look at the literature that tells me that it doesn't work. But what's interesting is these cases were basically overdenture cases. And when they did cut the roots, they did nothing to cover them. So basically what you had is a denture that was relined that was basically slamming up against these vital roots. So of course this is going to show some doubts. I mean, I don't think that that's the best way to gain the result you want. In Bauer's study, he buried the roots. And when he buried the roots and didn't slam up against them with a denture prosthesis, he said there was no problems with submerging vital roots. So we take a look at this case, and this is what we end up with. We like to cement these bridges with temporary cement. We take this bridge off. This is about a 1-year post-op. I see no inflammation, no reduction, no resorption. And this is what we term the root submergence technique for us. Covering it up, leaving it 2 to 3 millimeters subgingival, and then you have an implant, submerged root Pontic, an implant, submerged root Pontic, and then the implants on the back. On the right side, again, submerged root, again, maintaining the scallop, the natural color of the tissue. And this is what we're really looking to do. This article was published 2007, December, of the International Journal of Peri and Restorative Dentistry, with other cases were highlighted. And this is really another clinical tool that you can utilize. I hope that you will. If we take a look at this literature, and some of the literature that tells us that maybe we are and should consider it, an Oral Surgical, Medical Oral Pathology Journal, 1978, O'Neill said this procedure should be considered as an alternative to extraction of key teeth in an effort to preserve alveolar bone. 1978, somebody said this. What they suggest is periodic follow-ups should be done to rule out cystic formation, beveling the coronal portion so there's no sharp edges. The procedure should be done in 2 steps to allow the root canal to be sealed. Now this is something they did. They did not do vital teeth. And they said new cementum and connective tissue will form over the coronal surface, separating the dentin from the new bone. So the advantages from the article that we published would be that it maintains the attachment apparatus of the tooth, including the root, the cementum, and the periodontal ligament. Number 2, it maintains the entire surrounding socket and alveolar bone. Number 3, it preserves the oblique connective tissue fiber insertion to the gingiva. Number 4 is it preserves the blood supply to the gingiva through the maintenance of the periodontal ligament. Number 5, it's a less expensive alternative to extraction and utilizing bone grafts and GEM21s and PRGF. Number 6, it's more efficient in terms of less time needed for healing. And number 7, certainly for me, much more predictable from an aesthetic soft tissue response than placing 2 adjacent implants. What happens when there are no roots to submerge, Dr. Salama? I'm asking myself that question because I'm not going to let any of you ask me the question. So what do you do when there's no roots to submerge? How do you like that? I'm going to take out all the teeth that you would normally try to submerge. And look what this guy ends up with. A little bit of a defect, a type 3 defect. And this is what the defect looks like. And there's no roots for me to submerge here. But I got a big defect. How am I going to handle this defect? And you're going to see some of that by the next speaker who's going to show you how to do it with new materials. In this case, I custom shaped an irradiated allograft block, and I used PRGF over the top. I screwed it into place, placed implants on either side, and I used this bone not for implant placement, but to actually support the soft tissue. And I shaped it in such a way to see if I can support the interdental bone for the future dental papilla. I was not sure that this was going to work. We submerged it, made sure we do all the things we normally do with a block graft. And this is what it looked like. We're watching this, and you can see that this bone has been retained. It hasn't been loaded with an implant. We're just trying to retain the soft tissue utilizing this block graft. This is not an autologous block graft. It's an irradiated allograft block. We take the patient from something like this, a severe class 3 defect, and a patient that didn't want to go through block grafting from the lower jaw, and we're able to build up this area of the Pontic, not with a submerged root, but with a submerged block graft. And if you take a look at this area now, this is a post-op CT taken at approximately 18 months. You can see that that block continues to retain its position and support of that Pontic. This is now 2 years post-op. Look at the bone that's been placed. This is allogenic. You can also today utilize xenograftic blocks. This is what it looked like the day of cementation. This is the Pontic. This is what it looked like on X-ray, and this is the ceramics approximately 2 years out. So the effects of allograft and xenograft blocks, we're publishing an article just been submitted from the IJPRD of 5 case reports. I'm going to be perfectly honest with you. 5 cases were treated with block grafts from Tutagen. They went through the Tutagen sterilization process. All cases with type 3 vertical defects. One of the 5 cases, 20%, had a complication of early exposure and infection, had to be removed. The 4 other cases, follow-up for 2+ years, clinically and radiographically were within normal limits, and one of the cases I just shared with you. So another option for type 3 defects is to utilize this type of bone graft material. And I'm going to leave you with my last clinical pearl. And the reason I'm just going to show it to you rather quickly is because things change and you now have different tools to utilize these techniques. I believe that you'll see one of my colleagues, Eric Van Duren, who's probably going to speak more about this in greater detail on Friday. But in severe type 3 defects, such as this one, if you have a patient, she's already been through a hip graft, and she doesn't want to go through a myriad of different procedures. She's in her 20s, in her late 20s. She doesn't want to go through 2 years of multiple surgical procedures, but she knows that she wants an aesthetic final replacement of her teeth. In September-October of 2009, we published an article. It's now been published in all 3 parts, Part 1, Part 2, and Part 3 in the IJPRD, with myself, ceramist Christian Coachman, and David Garber, Marcelo Calamara from Brazil, Henry, and Guilherme Cabral, who's also a ceramist in our office. And what we started coming up with a suggestion of a different way to treatment plan these severe type 3 defects, utilizing artificial gingiva. That doesn't mean just pink porcelain. That's absolutely not what it means. I know many of you use pink porcelain when you come across a deficient area, but what we try to do is not use it after the fact, but actually to start the process of treatment planning it from inception. And what you see here is just some of the cases that we highlight in the article. All 3 parts are available for you, as I said before, for download. This is what she wanted to look like. This is the picture before the accident. We do a wax-up that includes not only the teeth, as she liked them, but also a wax-up that includes the gingiva that is missing. We transfer this wax-up into the patient's mouth. When the patient likes what she sees, we then transmit this information, the barium sulfate, to a CT scan. And what we talk about 3D treatment planning. And in Part 2 of this article, we talk about the different quadrants and how the surgeons have to address these defects differently. For those surgeons out there, how many of you are surgeons? Or slept at a Holiday Inn Express last night? What you want to do in these cases is not graft vertically. You want to graft horizontally. You want to establish keratinized gingiva, vestibular depth, but you do not want to try to graft it vertically, because what you're going to try to do in these cases is you're going to leave the interface for the artificial gingiva below the vermilion of the upper lip. And what you're seeing here is the framework with the wax-up of the teeth that are going to be replaced. And what we know now is where exactly the location is going to be of the interdental papilla within the smile line. We then have this situation. We have a flat ridge that we create. We're not trying to do ovate Pontics here. We're going to replace this area with artificial gingiva, utilizing a combination of opacious pink porcelain, very thin, and over the top, the chair-side utilization of composite artificial gingiva. You can do this chair-side, you pick the colors you want, or you can give it to the laboratory technician, and they can do it, and you can try it in the mouth. The advantages of this is that you have control over it, and you can repair it or add to it without having to send it back to the laboratory. And if things happen over the course of years and you have shrinkage of the tissue, you can simply add this in the mouth, unscrew it. The implants must be screw-retained. You cannot have an implant that is going out through the facial area of the future sets of teeth that we're replacing. So for the surgeons, not as many implants, place the screws lingually. We're going to use direct composite, place the tips of the papilla, and we're going to light cure this in the mouth, and then we'll clean this up chair side, remove the flash, and send it back to the laboratory for the final glazing and polishing. We're using Gradia from GC. It's an excellent product, gives you a lot of different color matches. So for the restorative dentists in the audience, this is something that really will be a difference in the way you're looking at these cases, because in these cases, as a surgeon, I sleep better at night when I know that I can manage this case surgically with a high predictability, a low amount of complication, and know that my restorative colleagues and my lab techs can finish the case off using their restorative skills. So what you're seeing here is the white ceramic, the pink composite resin that is added. And we take a defect like this with basically one surgical procedure and give her back what she really wanted was teeth that looked like the teeth she lost originally, what we call prosthetic dental gingival reconstruction of the defect environment. Lateral views, the right and left sides, and if you take a look at this case, a natural papilla here, and then the artificial papilla in the front areas. When she smiles, I think even for an educated audience like yourself, very difficult to ascertain what's real and what's not, because we left the interface below the vermilion of the upper lip, and we left it distally. So when I look at this concept, my conclusion from my discussions with you today is perhaps we have to look at it from a surgical standpoint and reconsider the role of grafting in the aesthetic zone by utilizing 3 different techniques that I've been involved with over the last several years. Submerged root technique, published in 2007, block allograft, which should be published sometime later this year or next, and the artificial gingiva, which has just recently been published in the IJPRD. I hope this gave you some clinical pearls. I'm looking forward to the next speaker, who's always been somebody I've been fond of and has wonderful material to show you. I thank Michael for letting me speak before this audience. I know many of you are friends and colleagues, and I look forward to the rest of the meeting. Thank you very, very much for your attention.